Hi, I'm Dr. Raj Aquila. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my series of online training webinars. Zygomatic arch. Product? Facelift. And depth? Deep. Perfect. Excellent. So we do not want a hyperprojection. She already has a little bit of abundant projection here, so I'm going to avoid that. And I'm going to go a little bit more lateral, literally to generate lift. This is not to generate projection. It's about to reposition the skin. And to do that, what I do is, you see, I almost start the lifting process here by just giving some slight traction to the skin, so that when I actually inject into that area, then I go straight to the target. And then when I release the skin, you see the skin is already fixed in a better position. You can see the slight tension behind it. Nice big aspiration. And then as I inject, this is about 0.1, because again, I'm controlling my volumes because I don't want to have any hyperprojection. And as I come out, watch the skin now. You see how it doesn't fall as far forward. It's almost being held in position by that kind of hammer and nail type of effect. Take the product and the skin and stick the two together, so I'm repositioning the skin properly. Now I'm going to come a little bit more medially, so we're going to go at the beautification point, so intersection of the lateral hair of eyebrow and the upper alar tragus line, which is lying right here. Okay, so product, Facelift again, we don't want projection. Superficial or deep? Deep, excellent. Protect the inferior part of the zygoma, and then again, we're going to go all the way down to periosteum. Make a nice clean aspiration, showing you a big bubble here. And then we inject. And this is only going to be 0.1. You see, in the previous case, I would use 0.2 because I'm really looking to project her more. And then again, the molding, this is critical. So in terms of the molding, we're going to go lateral. And then also, I'll go a little bit more superior as well. Right, so it's nice always to evaluate, I think, at different stages in the treatment. Now, can you see how in the lateral lid cheek junction here, she's a little bit more effaced. On the right-hand side, can you see that there's a slight diagonal depression here? And that's been indirectly corrected. It's just this mechanism here, just watch. So it just repositions the skin. And so that's all I've done. I just did that on the treatment side. The other nice thing that it's done is, if you have a look at the nasolabial fold, and its contour like this, and then if you look at this side, we're already starting that retraction process. Can you see? And that is because she has got very strong bony support. And because the bone is there, it's acting as an anvil for me to project the skin away from. And that means that the impact for my surface tension through to this, which is an endpoint for injection at 1 and 2, is much more impressive. You see, I'm able to pull on the skin in a much more stronger way. Here, in this view, by the way, look guys, you can see this really impressive effect from a sad eye into a slightly more rested and a happy eye, just by numbers 1 and 2 there. Okay, eyes to the ceiling now. Perfect. So what I'm going to do is, I'm just going to now just ballot that SOOF, and as I go up towards this region, I want to see what kind of support I can offer to the tear trough. This is the area here where my finger is. Corresponds to that little microdot. And this is actually, look, a lovely view, I think, of the nasolabial fold and the effacement that we get there, which is just really, really beautiful. Okay, so we're going to go steep through the skin and then through the superficial fat now to the SOOF. Now I pop through the muscle and I know I'm in the right place. Here's the aspirate. And then 0.05 cc is all it takes. We have a little tiny bump, no problem. I take the bump and I'm just going to now make it kiss the lid cheek junction just ahead of my finger. Now look at the difference in the infraorbital crease when I do this. So you see on the other side, she has, I would say, a deeper but also a more vertical crease. And on this side now, it just completely reduces. Now, if you look at the camera again, which is the red light on the surface, can you see the difference in the infraorbital region? So if I rotate you like this, and then if I rotate you back like this, so you can see the really nice effacement of the tear trough. Okay, perfect, well done. Can you see that on this side, The lower eyelid is hanging on this side slightly, and she's showing a slight scleral show, whereas on this side she's got a little bit more vertical elevation. Right? Now let's inject Ayla base directly and see if we can influence a couple of things. So we're going to obviously try and deal with the upper third of the nasolabial fold, but also try and help with the upper lip and maybe even the nose at the same time. This is the injection plane here, so it's going to be down onto the piriform. The artery is running in this orientation. It's a little bit more lateral to the ligament. So what I need to do is I need to get straight to the target, all the way down, touch the piriform, and then with two hands what I'm going to do here is I fix with one and then I pull like this with the other one. The bubble goes back in. Remember, this is just a vacuum bubble. So what we start to see now, you'll see that the nose is getting taller on her left side. You will see also that it's starting to narrow and that the left upper lip is starting to evert and it's starting to come towards me. Can you see? Now I come out nice and slow, gentle. And then in terms of the molding, look at that nostril. Can you see this? Yeah? So the nostril is coming up. And now, so what I'm saying is, who cares about the nostril? I'm talking about the pyramidal structure of the nose. It means that this is tented, okay? It's pushing the tip of the nose like this, upwards. Now I'll do a little mold underneath the alar dome, like this. And I'm basically squeezing the product underneath the levator labii superioris muscle. And maybe it's very subtle with the lip here. There's a slight little extra support of the upper lip, which is showing a little bit more mucosa on this side. Let's have a look at your animation. So show me a gentle kiss. Kiss more. Can you see what happened? Look at the perioral lines on the left-hand side, how I sawed them off now in the upper part of the lines. Kiss now again. And relax. You see this line here is extending all the way up, so kiss again. And look how these are now shorter. What does that mean? It means that I need to do less local injecting within the upper lip lines, and that also means that the volume is lower. It means that she has less of a chance of having a convexity like Marge Simpson, right? Okay, so now we're going to go down to oral commissure, and I think you might agree with me that this corner is starting to look like it's starting to climb more than how it used to be, which is down in the mouth a little bit. So first of all, I make a little tiny microdepot. And all I'm doing is I'm just giving a little bit of three-dimensional support to the commissure. Now I'm going to go anterior to the mandibular retaining ligament, and I'm just going to be within the inferior border of the vermilion. And it's a superficial injection. And you'll see the oral commissure just climbing on me now. Mold it out. Very beautiful. And it looks like she had a lip treated when you do this, because it makes the lip look wider, and therefore the structure is more of a positive one. Then I'm just going to treat the corner of the mouth and go vertical. So this is the little vertical strut that I was talking about, whereas for the lip, the treatment of the commissure actually begins from lower down. And now we have a really beautifully effaced corner of the mouth. We have a very distinct oral corner, which is sad. Let's face it. You know, the right-hand side is a more sad expression. The left-hand side now is more neutral, but slightly positive. If you make this too tall, you make them look a little bit contrived and a little bit sort of devious, you know, like they're smirking at you for some reason. So we just control that. And my limitation for this is actually going to be the same parallel line of the lower lip in the lateral third should mimic the same parallel line of the cheek and also the same parallel line of the jaw. Those three lines are running in the same unity. Right, now we're going to come further down. So remember, this is superficial and this is deep. So we're going to start to decrease the depth or increase the depth of the injection as I move from superior to inferior here. We're going to stick with Volif for the time being. And what you'll see now is the lifting capacity at the oral commissure becomes so much more impressive, because this is where I'm starting to treat causality and not just symptom, because all I did there was just treat the symptom. What you do is with patients who are having Vicross is tell them they're going to feel an irregularity here, definitely within the first week of treatment. But by the time they get to 2 weeks and they get to full molecular integration, there will be nothing detectable here whatsoever. And certainly nothing to the surface, but certainly nothing on the inside either. Okay, so now I compress. Can you see what happened? When I compress the tissue, look how she deforms at the jawline, but she's not deforming in the area that I've just treated because it's become strong. The surface tension has increased. Going a little bit deeper now. And bearing in mind, remember we had that submental artery that I drew on the face earlier. If you go too deep here, then you can get a bruise. And we commonly get bruising in this area, don't we? It's very common because you have the branches of the facial artery that run anterior to the mandibular retaining ligament. Coming further down now, it's getting stronger, but it's not quite there yet. I'm a little bit deeper. See how I changed my angle of attack here? And what's your name? Asking me about aspiration. Emma. So Emma, you know when I'm doing this, I'm not aspirating at all because I'm doing linear threads. In fact, what I'm doing is I'm doing a reverse tower. The Eiffel Tower, the base of it is here and the spire of it is here. Yeah, so coming back as I... Okay, also an important point here is that I'm not injecting behind the ligament because this is jowl fat region. And if you inject here, you are going to take this down. It defeats the objective of the exercise. So now to voluma. And the reason why we're using voluma is because I want to give strength here at the prejowl sulcus. Can you see already how on this side here, she has concavity within the cheek? And on this side, purely because of restoration of support here, so let me mimic that on this side. Can you see that effect? So because I've already done this to her, then she's already tighter through this lower cheek segment. Thank you. So we're going to go to the bone here now, to the periosteum. Stress and tension. This is now going to be anterior to the ligament again. So we're going to go pretty close to the inferior border of mandible on the periosteum. Make a nice big bubble. And sometimes in this area you can take a little bit more, so maybe 0.2, maybe even 0.3 in deficient patients. I can tell that she's not going to be a high volume patient in this area because she's already quite strong and projected there. Okay, thanks. And the reason why I gave Liz that syringe back is because I have to use a two-finger approach when I'm molding and massaging here. So I'm conforming it towards the inferior border of the mandible. And the objective here is that I want to make her jawline stronger. So once I've done that now, look at this now. Look at this side of the jaw is so smooth. This one is interrupted by a slight excess here. It's got a little laxity here, and it has excess below a concavity there. Whereas on this side now, everything is becoming much more positive. Thank you. Voluma? Let's look at the horizontal, so the vertical. See, there's less deformity on this side. Now we're going to appraise the horizontal concavity. And on this side, when I do this, see how she resists it a little bit more. However, we're going to make it a little bit better. So we're going to connect now the prejowl sulcus and the labiomental crease because this needs to be taken care of as well. We're going to go with Volift, actually. So we're back to Volift because remember, it's a hyperdynamic area. You know, I can see in her face that she is a little contemplative. You know, like quite pragmatic. Are you pragmatic? Are you a thoughtful person? Do you consider things before you do them? There you go. So, whereas she's the opposite of me. I just see it and I do it, yeah? So, maybe I won't have such a hyperactive mentalis, but these individuals will have hyperactivity here. And all I'm doing is I'm just going to give a mechanical blockade to stop this. So I'm choosing Volift so that it moves naturally. Otherwise, you might get a little bit of a block here, which is moving with the product, with the animation. So, stress to see where the weakness is, and I'm going to follow upwards towards the labiomental crease. And so, Emma, you were saying there about aspiration, and this would be the preferred technique that you use, which is needle moving, no aspiration required. And you know what? I agree with you. I think that's fair enough. Just because now things have changed with us a little bit and we are starting to now use more static bolus injecting in risk areas, we really have to do it for us. And just out of interest, Emma, what proportion of your filler portfolio would be formed by Ultra? What percentage? Volift of Orbella, okay, sure. So maybe you can start introducing Volift, I think, in these areas. Maybe switch your Ultra Plus to Volift. I was at a clinic in Australia, and they're basically offering a fairly flat price between all of the Juvederm products, which I thought was astonishing. But, and it works for them, so. All right, now we're going to inject labiomental crease. So at the midline here, patients don't like this, but look, I'm in the subcutaneous level. Because if I go too deep here, then I'm going to be in the mouth, and she doesn't want that for sure. She might want a drink, she might be thirsty, but she doesn't want HA. So as I inject there, and I just integrate it into the tissue, what I'm doing is I'm not just uniting the lower lip and the chin, I'm also helping to give some vertical support to the lower lip tubercles. And the change that we should see is this type of effect. And isn't this attractive when we do this? So we just give a little tower support, and then the lower lip pops out, it everts slightly, and that is mimicked by the support that we give here in the alar base. So in other words, there's a combination of upward tilt and eversion, and then this lower lip support, which shows a little bit more height. I mean, we'll do it directly, but I'll show you that that's the indirect approach. Now then, what we're going to finish the jawline with is just a little angle of mandible injection. I want to take her to here. Smile, relax, smile. Do you see? Okay, that's the difference. And watch the finger again. Smile, relax. 2 millimeters, smile. It's not much. Just even small lifting makes a huge impact for surface tension, especially when you've got good structure like this. She's a great model for this. Okay, so I pinch the skin. I'm going to show you where that bolus would be is 1 centimeter superior medial to the angle of the mandible. In the male patient, it's going to be exactly at the angle, which is going to be down here, and that one is going to be on the bone. So just for your ease of viewing, in fact, that blocks you completely. I'll turn it around again. I'm just going to pinch the skin up like this, and as I pinch the skin up, then I can enter the tissue, I can flatten off, and I'm in the subcutaneous level, then I'll release with the non-dominant finger. So I'm now in the subcutaneous fat. Make the aspiration here, because you've got, masseter with its blood supply, you've got external carotid, you have facial artery just medial to it, and then of course you've got the parotid gland as well. So I make my 0.1 to 0.2 maximum cc. After that's done, you'll see a little tiny bleb there under the skin. Take the bleb, stick it now onto the ramus of the mandible. So I'm causing an adhesion type of effect. And interestingly, I work with a facial plastic surgeon who does facelifts on some of my patients. When I first started using Vicross, some of those patients have now proceeded to have segmental, like lower facelift. And when he does an open dissection, he tells me that in this plane between skin and SMAS and muscle, or even bone in the cheek, he says he can see the tissue fibrosis. Because what we're doing is we're creating this little sticker or adhesion in the tissue, and that is conferring to some long-term fibrosis and a little bit of collagen formation. So after that's stuck, we can then evaluate what it's done. Well, first of all, one of the objectives here was that I wanted to get her towards around 94 degrees, and she's already quite square, so I wanted to soften her up a little bit here. And then we got the lower cheek lines. Here we go. So show me a big smile and relax, okay? And then we'll have a look at this side. And then show me a smile. Do you see the difference on the two sides? So you have lines that extend all the way down to the jaw because you have laxity and excess like this. And then on this side, she has hugely reduced lines. So smile. There you go. So we start to improve things just by doing this kind of needle approach. Now what we need to do is, and we've already made some changes here because look, she has concavity here. I've made her face more oval on this side simply by lifting the tissue. So by supporting the tissue and giving her this kind of lifting effect. Now what I'm going to do is we're going to deal with this infrazygomatic region and try and make that a little bit softer. So if you turn your head this way, thank you. I want to get to here, and I want to get to here, and I want to get to here, and also just above where I did the depot for the angle of the mandible. So of course, I've measured it, and I know that my trocar incision point should be around here. So just leave it in there for a second. Different people do different techniques. All I do is twizzle it around a little bit. I see some people that move it forward and backwards, and what they're doing is they're basically jabbing and prodding and poking potentially critical structures that lie in that area. So I just rotate it. The only thing I do for ease of access is as I come out, I make a small little flick there at the skin. Thank you. And then if you use a cannula in this area, then you need to try and access fast because the hole will definitely want to close up quickly. In terms of the technique with cannula, see already now, can you see I'm stuck? I'm stuck on the masseteric retaining ligament. So what I need to do is a two-finger approach whereby I'm gently encouraging the skin to fall on top of the cannula. If you start just trying to jab and ram in the cannula with no counter traction, you'll often find that you come against connective tissue obstruction. So there's my first one, okay? So I'm going to do my little comet tail, and then I'm going to come back like so. Then we do a second one. So again, little counter traction. Get in the right plane. It's got to be subcutaneous. There, I'm on the ligament again, and I'm just through it. Little counter traction here. And then make sure you're level with the ramus of the mandible and not behind that. Somebody asked me yesterday in Brisbane, how do you treat the pre-auricular lines? I said, treat the cause, don't treat the symptom. Don't chase after them with a needle, because you're going to get potentially a complication there. So then I'm going to go further down now. Just come out, reposition. And the cannula, see, it wants to go into a path of least resistance almost. And sometimes you need to recheck your depth there. And it had to re-enter the subcutaneous plane, because what I was doing there was I was entering a deeper tissue plane, and I was being obstructed by the ligament again. So I'm here, and then again, inject, and we withdraw. These are the comet tails. And we'll do one final one now. Again, I'm stuck on the masseteric retaining ligament. Subside, dissect, pass through, over the top of masseter muscle. You can see now where I am here. I'm at the angle of the mandible. So this will facilitate more jawline lifting. And then we come back, and then less as I get towards the injection site. Now, that's only not even half of it. The product is now in. You can see the little beads of material there. So what I have to do with the beads is I have to mold them. And I want to mold them laterally, so, like this, and stick. And I want to mold laterally and then stick. And I'll do that until I can feel that all my little tiny depots have all fused together. And when I run my finger across the cheek here, I can feel that it's as smooth as a baby's bum. Yeah? And then I know it's done. And we don't stop doing that until that's complete, because actually this is one of the main mechanisms of the lifting of the lower cheek skin. So just like this, and then we're complete. Perfect. Nice. Let's have a look at your face shape now. So can you see? Yeah, she becomes much more like an oval. And, okay, she wants to look softer. Did she achieve a softening? Yeah. So we stop at this point. Because otherwise, I don't want to degrade my result by even moving from an oval more into then a circle. Okay, because I've seen people going crazy here, and they end up becoming over-projected in the lower cheek like this. We still need to retain this degree of support, but whilst not influencing face shape too dramatically.